issue in children. They present with the inability to speak. They're totally aphasic. So if you do EEG, you can pick up the shear discharges. Then what are the medical complications following seizures? So you should be aware of it, especially elderly person. Increased cardiac output can result in increased hypertension, hyperglycemia, metabolic disturbances like lactic acidosis. If the patient is having severe tonic-clonic movements, they can end up in myoglobinuria and can result in renal failure. What are the the implications of status epilepticus is that if you cut down the duration of seizures, we can prevent the morbidity. Suppose if you allow the seizures to grow, that is the longer the duration of seizures to control, they can end up in cardiorespiratory failure, electrolyte imbalance, rhabdomyolysis, resulting in renal tubular necrosis, hyperthermia, multi-organ failure, and rise ICP and cerebral edema. That's a reason to prevent both mortality and morbidity, or to cut down the duration of status epilepticus. This is a graph showing the various both the convulsive, myoclonic and the non-convulsive seizures, how they present in the phase 1, phase 2, phase 3. So you can see in phase 3 they can have respiratory compromise. That is, if you allow the patient to proceed with the status, you can end up in so many medical problems and sometimes resulting in high mortality rate. So it is classified into phase 1, phase 2, phase 3. So in phase 2 you can have the lactate can build up, pH can rise. So in phase 3 they almost have cardiorespiratory failure, hyperthermia, etc. What are the complications of prolonged existing status epilepticus? They can have hippocampal sclerosis. They can lead to again hippocampal sclerosis with post-scar epilepsy again. So that's why, because these hippocampus, thalamus and cerebellum are sensitive to hypoxia. So whenever the status epileptic duration increases, it causes hypoxic brain damage in among this area of the brain. Especially hippocampus is more sensitive. In childhood, again hippocampus sclerosis can develop, and they can lead to again later on in adult stage they develop any new onset epilepsies. So you should be careful about this. Aware of its complication if you don't treat in at right time and right place. Coming to non-convulsive status, I told earlier they can usually cause a severe impairment of consciousness. Then motor manifestation can have mild motor like twitching of the face, eyelids, etc. Sometimes, as I told earlier, is mistaken for psychiatric disorder. So how to differentiate? One is clinical judgment, and is EEG. Clinical judgment, where check for the detailed orientation, time, place, person, concentration, attention, everything. At least in psychiatric condition, they can have at least the orientation is preserved. Whereas in a non-convulsive status, they're totally confused. Then, of course, followed by EEG. What is refractory status epilepticus? It's a term used when you inject diazepam or lorazepam, then anticonvulsant. If the patient is not responding, then it's called refractory status epilepticus. Usually, it can happen after 20 to 30 minutes of continuous seizures. So the patient becomes refractory to your ordinary drugs. It's called refractory status epilepticus. It constitutes about 40% of all status epilepticus. The predictors are presence of encephalitis, then hypoxic brain damage. These are the predictors to develop refractory status epilepticus. What is super-refractory status epilepticus? Super-refractory status epilepticus, those status epilepticus not responding to the anesthetic agents. For example, midazolam, then propofol, thiopentone. If they're not responding, then we call it as super-refractory status. Very difficult to treat. They carry a high mortality rate. It constitutes about 20% of all status epilepticus. So only status epileptic definition, that is continuous seizures minimum for 5 minutes and without recovering of consciousness in between. It's called status epilepticus. Refractory means they're not responding to your first line of drugs like lorazepam or valproate or levetiracetam or phenytoin, phenobarbital. Then super-refractory means they're not responding to the general anesthetic agents. So you should be aware of 3 terminology: status, refractory status, and super-refractory status. Management of status epilepticus. The first thing is I'm telling you, you should identify if the epilepsy patient, whether he is a drug defaulter then you have to correct immediately. You have to start the old drug first. Then whether there is any infection, you have to treat with appropriately. You have to investigate MRI or CT scan followed by lumbar puncture. Look for any infection. If it is autoimmune encephalitis, you should look for autoimmune antibodies in them and then start appropriate therapy. So one is these are the flow chart of what we follow. One is termination of status epilepticus. Next is prevent of recurrence of seizures. Third is the management of respiratory cause like metabolic condition, infection, etc., etc. Then management of complications. When you come across in the emergency, first you should look for airway, whether I am protecting his airway or not. That is, you should give oxygen appropriately depending upon his requirement. Then if he is aspirated, you should intubate him, and you should immediately send for a blood various parameters. A simple example is hypoglycemia can present seizures. So look for the glucose level, CBC, renal function test, calcium, magnesium, especially in children, calcium, magnesium is important. Electrolytes, sodium, potassium, AED levels. If possible, you do AED levels, anti-epileptic drug levels. Then, of course, continuous EEG monitoring. Before that, putting it ICU, if possible, to get a CT scan or MRI. Then, once you put into ICU, you should also look into it, any toxicological causes. Especially nowadays, young people, they have a lot of substance abuse disorders you come across. One of them known to produce seizures in status. I come across a few patients like that. The family members may not be knowing because the patient may not disclose with them. So it's very tough to deal with such cases. And that's why you should, in abroad, what they do is they got a toxicological panel. Both serum and urine they send routinely. But India, I feel it's only urine they're doing now. Serum, very few places they're doing. So toxicological screening is very important. Continuous EEG monitoring is a special note I want to bring, especially patient with status epilepticus. If you have got a good ICU setup, you should put him on continuous EEG monitoring. Like continuous ECG monitoring, what you call Holter monitoring, we call it as continuous EEG monitoring. Because it helps to identify whether we are cutting short the duration of status epilepticus or not, and also it helps us for managing with the IV drug preparations. For example, if the patient comes to you you start on lorazepam, and with this single dose of lorazepam, if the EEG discharges comes down, that means you are safer side. If it's still prolonging, then you have to scratch your head, start adding different anti-epileptic drugs, which I'm going to highlight later on, then followed by even anesthetic agents. Suppose if the seizures are well controlled and electrographically, that is continuous EEG monitoring also showing there is no shared activity in the brain, then we can slowly reduce the parental IV preparations of anticonvulsants over a period of 12 to 24 hours. So that's why this continuous EEG monitoring will help us actually. Indication for continuous EEG monitoring is status epilepticus, one of the status epilepticus, then coma, post-cardiac arrest. Then if you suspect a non-convulsive status, I told earlier, they are present with confused with psychiatric condition. In such cases, we should do continuous EEG monitoring. Continuous EEG monitoring, how to stop the drug, it depends upon certain parameters you have to follow. Presence of burst suppression pattern, that is EEG showing minor electric discharges followed by flat line. If it is the flat line duration is more than 8 to 10 to 20 seconds, we can guess that the seizures are getting controlled. Then we can start reducing. Or sometimes if you want to wait for complete suppression of EEG, that also possible. But only problem with complete suppression of EEG is that you have to be careful because the patient can have a respiratory depression, other problem with the continuous anticonvulsants. Then diffuse beta activity may also suggest sometimes there is seizures coming under control. Drug of choice, as I told, benzodiazepine is the first drug of choice for all status epilepticus. In the olden days, we used to give diazepam. Nowadays, we are not giving diazepam because of its severe sedative effect plus it has got respiratory depressive effect. So now it is slowly replaced by lorazepam. Then if you have midazolam, especially IM, what you call inhalation form or subcutaneous injection form or nasal spray, especially in children, we can give a trial. Of course, what we in India we have is the IM preparation is available, but IV is also available. Normally, as a first antidote, we can give IM or a spray or nasal spray or subcutaneous form. Even in the US, they are coming out with a sublingual form of midazolam. It is not yet come in India. Rectal diazepam usually is effective in children. That's the only area where diazepam carries more advantage than lorazepam in children with rectal diazepam. Because rectal diazepam is easy to administer. In the emergency ward itself, we can inject like any enema, we can inject to the rectum straight away. But only thing is sometimes very rarely it can cause rectal irritation. Say in US they got buccal midazolam, I told no, sublingual form, the international midazolam. But these are still in experimental stage, especially buccal and international midazolam. Diazepam usually is given 10 milligram, but you have to monitor the respiration rate. They can have respiratory depression. Lorazepam is now the current drug of choice for the management of status epilepticus. What usually we calculate the dosage based upon the body weight, but in adult we go for somewhere between 2 to 4 milligram, sometimes very rarely 8 milligram. But you should have a ventilator in standby if you give 8 milligram of lorazepam, because they can have severe respiratory depression sometimes. So safer is 2 to 4 milligram in adult. In children we give about 0.1 milligram per kg body weight. Okay. If the benzodiazepine are successful in stopping this thing, you can switch over, you can add on maintenance dose with the regular anticonvulsants like phenytoin, phenobarbital, valproate, etc. Suppose if the etiology is irreversible, for example, I told earlier we should correct metabolic conditions, toxic conditions. Then if it's infection, appropriate antibiotic. If it is a meningitis, of course you have to start meningitis dose of antibiotics, etc. So coming to the regular anticonvulsants, once she's are stopped with lorazepam, we can give, there is a various drug of choices, but what we normally follow is phenytoin first. Bolus dose about 20 milligram per kg body weight. Maintenance is around 5 to 8 milligram per kg body weight. Fast phenytoin 20 milligram again, and usually they given at a rate of 150 milligram per minute. Then sodium valproate, so we give somewhere between 25 to 40 milligram per kg body weight as a start dose, then followed by maintenance dose. There is a difference between the fast phenytoin and phenytoin. Usually fast phenytoin is safer compared to phenytoin because it's got lesser IV line irritation. Lesser chance of developing thrombophlebitis and a lesser chance of developing cardiac complication compared to phenytoin, regular phenytoin. Phenobarbital, we don't have actually in India IV preparation. Most of the time we end up in giving IM preparation, but IV preparation is the drug of choice. Usually it's given 15 to 20 milligram per kg body weight. They can cause sedation and as well as hypotension. You should be careful. Sodium valproate, I told earlier, it is also one of the first line of drug for management of status epilepticus. Refractory status epilepticus. That is, when you are not responding, the patient is not responding to the lorazepam and regular anticonvulsants. What do you do next? Then next is you should start with the you can recognize by electrographically also where is a continuous EEG discharges. So how to manage this? We can give propofol, thiopentone, or midazolam. One of three you can choose. It depends upon the center to center with their experience with these three type of drugs they choose. Normally we give midazolam 0.3 milligram per kg body as a bolus. Then maintenance dose 1 to 2 or 4 even 5 milligram per kg per hour. We give midazolam drip. Normally we give for 12 hours. We may extend another 12 hours. Then if EEG showing decline in seizure activity, we start tapering it. But we need ventilator for this midazolam. It's very difficult without ventilator. Or thiopentone. Thiopentone again bolus dose is 100 to 250 milligram followed by maintenance about 3 to 5 milligram per kg per hour. Okay, usually given in infusion form. Slowly we give per minute. It has to be given and then it has to go about 3 to 5 milligram per kg per hour. For example, if the patient is weighing 50 kg, 5 milligram per kg per hour means every, for example, every hour you will be giving around 150 milligram per hour. The dosage of thiopentol, and it has to be go over a period of 12 to 24 hours. Propofol is also a drug of choice for the management of refractory status epilepticus. Again, the bolus dose is 2 milligram per kg, followed by maintenance dose about 2 to 10 milligram per kg per hour. For all these things, we need ventilator. Without ventilator, it is difficult to give. Even pentobarbital has been tried, but of course, we need to monitor the respiration, and sometimes they cause hypotension. Then the regular anticonvulsants, we know must be known, apart from valproate, phenytoin, phenobarbital, we got levetiracetam, again 25 to 40 milligram per kg body weight. Locosamide also been tried in status epilepticus. There are a few case reports showing decline of status following locosamide administration. Usually we give 20 ml infusion twice a day. Coming to the in case of a super-refractory status epilepticus, if the status epilepticus not responding to your even propofol or midazolam or thiopentol, then we have got inhalational anesthetic agents like isoflurane, desflurane, ketamine. Ketamine has been tried in a super-refractory status epilepticus. But again, for ketamine, we should have well set up ICU and also the ventilator. Ketamine is an NMDA receptor antagonist. Studies showed it is superior compared to other group of drugs, and its efficacy in extremely refractory SC has been documented in both children and adults. Usually, it's not a cardiac depressant, and hence does not cause hypotension. I think ketamine has also been used by psychiatrists for other psychiatric conditions, or also for diagnostic purposes also. Diet, sometimes in children we try a ketogenic diet in status also. Suppose if the patient is not responding, this induces ketosis in the body and suppresses the seizure activity by release of the so-called molecule called leptin. Steroids and immunotherapy, especially in autoimmune encephalitis and NMDA receptor encephalitis, give steroids. Immunotherapies like plasmapheresis or gamma globulin will give a trial, especially in young individuals. In a rare conditions, one may, with all very rare, we end up in resective surgery of the brain where the epileptic area activity is very high. We have to resect that particular area. Rarely we do vagal nerve stimulation, hypothermic therapy, etc. This is a flow chart about the drugs in status epilepticus, midazolam, lorazepam, followed by general anti-epileptics like phenytoin, valproate, etc. So, thank you.
Hello, Doctor. Thank you, Doctor. Thanks a lot for your wonderful discussions and deliberation. I hope all the attendees who are present today have enjoyed it. Now, as we discussed earlier, doctors, like now the session is open for Q&A session. Either you people can choose the raise the hand digitally, where I'll be allowing you to directly ask questions with Dr. Sanjeev CC sir. If not, you can type in your questions and you can get the answers from Doctor himself directly. So over to you, doctors. Kindly post in your question, or you people can raise the hand. I'll be allowing you to directly ask questions. Sir, Dr. Shashi Gupta sir has asked one question, sir. Sanjeev sir. Sir, what is the role of levetiracetam? Generally, we don't use lorazepam. So, what is your comments?
No, lorazepam is a drug of choice for status. When you see a patient getting continuous seizures, you have to give first lorazepam. This is the thumb of rule, what you call. Then, if seizures are controlled, then go for either levetiracetam, phenytoin, phenobarbital, valproate, etc. So it's straight away nobody will give levetiracetam. When you witness a patient getting continuous seizures, you first give lorazepam.
Dr. Shashi Gupta, sir, I have taken you as this thing. Do you want to ask further any questions, sir, on
Yes,
related to?
sir, if a patient is already on anti-epileptic drug, sir, and has stopped for last 6 months, sir, and has got seizure now, sir, how should we proceed, sir? Like the old medicine only shall we start, sir?
Best is to start the old drug, which is responded initially, because the brain accepts the old drug first. So suppose he is taking phenanthanol valproate, you start that drug.
And sir, generally when we attend as a casualty, sir, we give levetiracetam, sir.
The levetiracetam only if seizures are controlled to prevent further recurrence, you start levetiracetam. But when you see a patient getting continuous seizures, you have to give lorazepam.
Lorazepam, sir.
Yeah.
Sir, when to switch on to oral medication, sir? After how many days, sir? Or
depending upon your the patient recurrence of seizures. Suppose if the one or two injections, if you feel that is seizures are well controlled and is conscious oriented, then the next day you can start off oral medications.
Thank you, sir.
Because for psychiatrists also very important. I'm telling you, psychiatrists, many antidepressant, antipsychotics can prescribe seizures. You should be aware of the management of seizures.
Sir, if the alcohol withdrawal cases are there, sir, and we are suspecting
alcohol withdrawal seizures, I told earlier, no?
Yes, sir.
It can end up in status also, but rare. Yes. Can end up, and 20-15% can end up in status. So best is to give, of course, you have to give thiamine, other things, hypoglycemia is there, thiamine is there, you have to give. Then best is to lorazepam, followed by other regular anticonvulsants.
Sir, in the presentation, sir, you told, sir, like 4 mg of lorazepam maximum.
Yeah, adult, we go up to 4 mg. Okay, but rarely they can go up to 8, provided you got a good ICU setup, ventilator setup, anesthetist to be backup use immediately. Suppose they can have severe respiratory depression.
Sir, generally, but in psychiatry, sir, we give lorazepam up to 16 mg, sir, in a day.
No, start dose I'm telling you.
Okay, sir.
Start dose is different from maintenance dose.
Yes, sir.
Yeah, start straight away, heart may not take. Heart and lungs may not accept straight away.
Okay, sir.
Again, depend upon individual body capacity. Okay. Go with at least 3 to 4 milligram, then build up. But provided you should have backup. Straight away, don't go for 8 mg. It's a dangerous.
Dangerous, sir. In child, sir, half the dose, sir.
0.1 milligram per kg body weight. 1 to 2, but you calculate 0.1 milligram per kg weight. See, in a status, you cannot weigh the weight, no. It is your judgment.
Yes, sir.
You look at the patient, what is approximately, think, then give.
Thank you, sir.
You read today, what are the antidepressant, antipsychotics prescribed seizures?
Okay, sir.
Because very important. You may end up in your own, in front of you, they can have seizures.
Yes, sir.
I have seen.
Particularly OCD patients, when we rise the...
OCD, antipsychotics.
Yes, sir.
Patient treating schizophrenia. Schizophrenic patients are vulnerable to seizures.
Clozapine, sir. Clozapine has the maximum risk.
Yeah. You should be aware of it, management. You cannot wait for till neurologist comes or other doctors comes. No, you have to manage, I'm telling you. In a remote setup, you need to learn, I'm telling you. If you are practicing in the rural areas or towns, you may not have access to neurologist or other people, anesthetist always.
Yes, sir.
Okay? Because the attendants will ask you, you only treated, no? I mean, antidepressant, antipsychotics.
Yes, sir.
They expect you to treat. Because you should be aware of it, I'm telling you. I don't know why many psychiatrists are not come today. This is an important topic even for the clinical practice also.
Yes, sir.
Doctor, we have around 5 to 6 psychiatrists who are present.
Okay.
Out of 12 doctors who are here.
Okay.
Doctor, any take-home message you would like to give, especially for the psychiatrist, as you said, it will be quite
be careful when you choose the antipsychotics, antidepressant carefully. If the possibility of seizures, epilepsy is there, be careful. Go slowly, don't hike up this thing, and better give instruction to the attenders. Look for watch out for any side effects like seizures and all that thing. That's very important. At the same time, metabolic parameters you should do evaluation. Hyponatremia, creatine level and all, very important.
Sir, how much time we should wait after giving lorazepam, sir?
Lorazepam, see what happens, usually the action starts immediately, within few minutes. Wait for 5 minutes. If it is still not continuing, another dose you can try it. Then go for the anesthetic agents.
So Propofol doesn't cause any respiratory depression, na, sir? So we
can cause
Propofol
syndrome. Yeah, it's a Propofol syndrome. Okay. They can cause acidosis and all.
Yes, sir. But that is yes.
What happens normally after lorazepam, repeat. Then we start regular medicines like levetiracetam or valproate or phenytoin. Then if it's still continuing, then you try Propofol or midazolam drip. Okay, this should happen within all 30 to 40 minutes.
Yes.
Okay, they roll off first first few minutes. Actually, they say even 15-20 minutes. If it is still not able to control, go for anesthetic agents.
Thank you, sir.
Okay.
Yeah, doctors, any further question?
It's okay.
Yeah. Thank you, doctors. Thanks for the I would like to take this opportunity to thank Dr. Sanjeev CC, in particular, to have accepted our invitation and to have shared his findings and opinions today, and